Hello, everyone. Welcome to our Zoom meeting. Today, we're going to have 4 topics, and Dr. Rayan and her team will be presenting. So when you are ready, Dr. Rayan, please go ahead.
Okay, thank you so much, Dr. Nader. Hello, everyone. Good evening. I'm Dr. Rayan Omar. I'm the team leader of the Orange One team. Today, inshallah, me and my team members will present 4 topics. The 4 topics in and it will be presented by me. And the second topic will be the full guide to writing your literature review. It will be presented by Dr. Ayah, inshallah, and the Humanoids, and it will be presented by Dr. Malaz. And the last one, the ChatGPT tutorial, and it will be presented by Dr. Lojaine, inshallah. So I will start by myself, inshallah, and I will present the cardiovascular diseases. Just let me to share my screen and tell me if my screen appear to you or not, okay? Just give me a second. Okay.
Hello everyone. Assalamu alaikum.
Alaikum salam wa rahmatullah wa
Alaikum
barakatuh.
salam.
Does my screen appear for you, everyone?
Yes.
Thank you so much. Thank you. So, good evening, everyone, again. Today, inshallah, I will start with the cardiovascular diseases in elderly. It's a very interesting and a very beautiful topic because I love cardiovascular system already, and it's really very important, particularly the vascular conditions in elderly people or in the geriatrics. So I will start. The cardiovascular diseases in elderly. The cardiovascular diseases, is the leading cause of death in population more than 65 years old and above. And 70% of adults, more than 65%, will have at least one cardiovascular condition. You know, when I'm talking about the cardiovascular conditions, I'm talking about the hypertension, the ischemic heart disease. We will mention that in the next few slides, inshallah, heart failure and all the things. And the prevalence rises sharply after the age 75, of course. But I want to highlight something here is the hypertension, you know. Just wait a minute. I'm sorry if my Zoom or my screen is not shared now.
It is shared with the title Why CVD is Different in the
Okay, sorry for that. I will fix it. Tell me now if it's appeared or not. Can you see my screen?
Now, yes, I see so. Just move it. Yeah.
Okay. Okay, so if you can see it, I will continue. I was talking about the hypertension because the hypertension affects...
Dr. Rayan?
Yes?
Do me a favor.
Yes.
Just unshare the screen total, go out, and then go back to the presentation screen. You can share the presentation screen.
Okay, I will do that. Sorry for
Thank you.
the delay. So I will continue if you can see my screen.
Yes.
Okay, thank you so much. So going back, everyone, the cardiovascular disease in the elderly, it's a very important topic. As I said, it's the leading cause of death is in population more than 65 years old. And 70% of adults more than 65 years old will have like at least one cardiovascular condition. As I mentioned, it could be like hypertension, ischemic heart disease, heart failure, valvular heart lesions, something like this. And the prevalence rises sharply after age 75. The hypertension considered to be the most common prevalent cardiovascular disease in elderly. About 70 to 80% of elderly will have hypertension. The heart failure and atrial fibrillation are age dominant. That means elderly people above 75 years old will have heart failure or atrial fibrillation, and heart failure, atrial fibrillation, considered to be the main cause of hospitalization and disability in patients. And majority of cardiovascular disease deaths occurs in older adults, unfortunately. So why cardiovascular disease is different in elderly? As you know that the physiology of aging, we have our cardiovascular system, we have the aorta, we have the left ventricle, and we have the mitral valve, and also we have the aortic valve. Okay, with aging, the aorta itself, it will be affected. The elastine in the aorta, it will be decreased, and this will lead to the stiffness of the aortic wall. So the stiffness in the aortic wall, it will affect the blood pressure. So the systolic blood pressure will start to be increased with time, with the loss of elastin. We have another thing. Elderly people should have like some baroreceptors in their aortic arch. You know the baroreceptors. The receptors that sense the blood pressure. If there is high blood pressure, they will be stretching in the receptors, and it will go to the to the cardiovascular center in the brainstem to activate the parasympathetic nervous system to decrease the blood pressure, and vice versa. If there is hypotension, the stretching will decrease, and the cardiovascular center in the brainstem, it will activate the sympathetic nervous system to increase the blood pressure. In elderly people, the baroreceptors will be not actually desensitized, but the baroreceptors will not function like the adults. So it will be affected. So those people will be at high risk to develop cardiovascular complications, particularly the hypertension. And in elderly people, we are affected from the hypertension because, of course, it's one of the causes that will lead to fall. It will increase the fall risk. So cardiovascular disease itself, it's different in elderly because already the age itself is a very strong risk factor for the development of cardiovascular diseases. We have another thing, the multimorbidity. I have been working lately in the geriatric medicine. I have seen many patients. All the patients that I have seen or I have seen, the patient will start to complain of multimorbidity, like the patient will have diabetes mellitus, will have hypertension, will have ischemic heart diseases. So all these people will have multimorbidity, not just only single condition. So the treatment of cardiovascular diseases in elderly people, it will be affected by the other conditions, like the treatment of hypertension or treatment of heart failure in patients with diabetes mellitus or in patients with chronic kidney disease. Of course, it will differ. It will not be the same. This is the challenge here. If you want to treat a cardiovascular condition in elderly patient, you will find that he has another condition. So you should be very careful in prescribing the medications, and you should have like a strategy to pick up the medication which is useful and has a benefit for this patient. Okay. And of course, the frailty. The frailty in elderly, all of you know that elderly people could be frail, right? Because with elderly or with aging, the physiological response will decrease. Our body, the response of the body will decrease. The body will not have the ability to compensate normally like the adults. So the frailty also contribute in the cardiovascular diseases in elderly and the outcome of it. And of course, the polypharmacy, as I mentioned a few seconds ago, the multimorbidity, the condition conditions, like the conditions that are associated with the cardiovascular diseases. Of course, the patient will receive the medications. Those medications could affect the cardiovascular system. Like there is some medications used for treatment for other conditions, but it can lead maybe to hypotension. Hypotension will decrease perfusion to the brain, to the heart. So it also can contribute to the cardiovascular disease, or to affect the outcome of the cardiovascular diseases. So cardiovascular disease, really, it's different in elderly people due to aging physiology and multimorbidity, frailty, and polypharmacy. So I want to say something here regarding the aging process. Of course, as I said, like a few seconds ago, we have a stiffness in the aorta. There is something very important here I want to highlight regarding the cardiovascular diseases in elderly people or population. You know, when there is high pressure, high systemic pressure, I said the systolic pressure, it will increase. When it will increase, it will put a high pressure on the left ventricle. That means the left ventricle will hypertrophy. It will increase, the left ventricle will increase the thickness, so it can overcome the high systemic pressure in the aorta. So what will happen? What will happen is that the left ventricle will be hypertrophied, and once it's hypertrophied, it means the blood supply should increase to the left ventricle. So this will predispose to the ischemic heart disease. Aging process itself, it will lead to the left ventricular hypertrophy, and this means that the heart needs more blood supply, and it will predispose to the ischemic heart disease. And of course, one of the most important thing is that the hypertension is commonly found in elderly people, and also hypertension will lead to the left ventricular hypertrophy. At the end, what is the problem? The end, the end story of this is that people with aging and hypertension, unfortunately, at the end, this will lead to heart failure. But which type of heart failure? It will lead to heart failure with preserved ejection fraction, because this is the most common heart failure in elderly. We have, we will see the heart failure in the next slides, but the heart failure itself, it's classified into two parts: the heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Preserved ejection fraction, it's usually called diastolic heart failure. The problem is in the relaxation of the left ventricle. So the blood will come to the left ventricle, but it cannot relax totally. So the ejection fraction itself, which means the stroke volume over what the end diastolic volume minus the end systolic volume, it will give us the ejection fraction. Because already the left ventricle is small, the ejection fraction will be preserved. It will come like a normal ejection fraction, and this is called diastolic heart failure. It's very, very common, or it's the most common type of heart failure in elderly, because the aging process and the hypertension, which is very common in elderly, it will lead to the diastolic heart failure, or heart failure with preserved ejection fraction. Okay, so arterial stiffness, left ventricular hypertrophy, diastolic dysfunction, all these could occur with aging. And also, of course, valvular calcification. Elderly people will start to have degeneration in their tissues, particularly the connective tissue, the tissue in the aorta, particularly the aorta, because the aortic valve calcification is one of the most common valvular lesion that occurs in elderly. So this is what I want to talk about: cardiovascular aging and the complication of it. So let's go to the cardiovascular risk factors in elderly. I will just let me to remove this. So we have many risk factors for the cardiovascular conditions. First of all is the age. As I mentioned, the aging physiology, it's very strong, non-modifiable, unfortunately, risk factors for the cardiovascular diseases, even if the patient did not have any other comorbidities like hypertension, like hyperlipidemia, diabetes. If he was just elderly patient, this will predispose the patient to develop ischemic heart diseases or cardiovascular complications. Okay, so the age is considered to be the strongest and non-modifiable risk factor. The hypertension is very, very, very important because it's the major driver of the cardiovascular diseases, as I mentioned, and it's modifiable. If we control the blood pressure, that will help us to prevent the complication that would occur from the hypertension itself. But there is something very important in the elderly people. If you want to control the hypertension, we should not control it aggressively, you know. If we started to control the blood pressure aggressively, this will affect the elderly people. Why? Because we said they are frail. Their body cannot compensate easily. So if we gave like anti-hypertensive medications in an aggressive way, this will predispose to the hypotension. And of course, hypotension in elderly patient or frail patient, this will be predisposed to fall and risk that to develop some complications from the fall itself and from the hypotension. Okay, and the hypotension, of course, will lead to decreased perfusion to the brain and to the kidney. You know, elderly people have lost the or decreased the autoregulation of the kidney and the brain, so they are at risk factor to develop severe hypotension even from minimal antihypertensive medications. Okay, so we have the hypertension, we have the diabetes. Of course, you know, the diabetes predisposed to atherosclerosis, and atherosclerosis predisposed to the ischemic heart diseases, and this is very important. Also, it could be modified if we control the blood glucose, and of course we don't want also to do aggressive control to the blood glucose or to do like severe hypoglycemia in elderly people. We have dyslipidemia, of course, you know, the dyslipidemia, particularly the LDL, which will build up in the endothelial cells of the blood vessels and predispose to the atherosclerosis and ischemic heart disease at the end. And of course, the smoking, persistent risk even in old age. But if the patient stopped the smoking for a longer period, this could have like a good prognosis for the patient. And we have obesity and inactivity. Of course, the obesity and inactivity predisposed to the cardiovascular remodeling also. So the hypertension and heart failure with preserved ejection fraction was seen in people, in elderly people who were inactive and obese. We have another thing, the chronic kidney disease. Of course, you know, patients who have chronic kidney diseases, they will start to develop some calcifications in their blood vessels. And at the end, the calcification of the blood vessels will affect the blood supply to the heart. And this will lead at the end to ischemic heart diseases. Okay, frailty and inflammation. The frailty itself, aging process, there will be like inflammation in the blood vessels. And this will affect the outcome of the cardiovascular diseases or the treatment of the cardiovascular disease itself. It will be affected by frailty and inflammation. So what are the common conditions what are the common cardiovascular diseases in elderly? Of course, you know, we have the hypertension, we have ischemic heart disease, we have heart failure, we have atrial fibrillation, we have valvular diseases. So all of these are very important conditions, cardiovascular conditions in elderly. And we said the hypertension is the most common prevalent condition. So the hypertension is most common cardiovascular disease in elderly people 65 or more. And the isolated systolic hypertension, this could occur, as I mentioned, due to arterial stiffness or aortic stiffness. It will lead to isolated systolic hypertension. The target blood pressure is individualized. It's based on the patient. We are not treating the age only. We are treating the patient himself. And you are not treating one condition. You are not just want to treat the blood pressure. You want to treat the patient as whole. So it should be individualized based on the patient condition, based on his frailty scale, mild, moderate, severe. You will start to manage the blood pressure. But as a rule, you will start low and go slow. With the medications, as I mentioned, elderly people could be frail, right? And this could be classified into mild, moderate, or even severe. So that means their physiological response will be decreased, not like the normal people or not like the adults. So elderly people cannot compensate well for the complications. So if we gave like antihypertensive medication and the patient developed, the patient was not well hydrated, or we give something like diuretics or something like this to treat the patient, and suddenly he developed hypertension, we should be very careful in this situation, because elderly people cannot compensate the aggressive treatment of the aggressive treatment of the hypertension itself. What I'm trying to say is that we will start with low doses antihypertensive medications, and if it was not controlled, the blood pressure was not controlled, we will go slow, we will increase, or we will add another medication. But very carefully. Also, we want to avoid the polypharmacy in elderly people. Polypharmacy means that we have 5 medications or more, because elderly people have some changes. Their renal function not like the adults, their liver function not like the adults. So the clearance of the drug itself, it will be affected. So we are trying to avoid the polypharmacy for elderly people. What I'm trying to say here is that I just want to mention one thing very important. The treatment is individualized, and we will try to avoid the aggressive control of blood pressure, and we will try to give him the necessary medication that could have a benefit on the long-term treatment on morbidity and mortality, of course. Okay, so that's what I'm trying to say. And of course, avoid over treatments and fall, because antihypertensive medications, if was used aggressively, it will lead to hypotension and predisposed to the falls and all the things. So we have thiazide, we have AC inhibitors, ARBs, calcium channel blockers. All of these could be used, but in a careful way. So the treatment of hypertension, I can mention this, the thiazide diuretics like chlorothalidone, like the chlorothalidone, okay? It's proven that mortality, it proves mortality reduction in elderly, proven that it will reduce, or it reduced the mortality rate in elderly. This is the thiazide. We have also the AC inhibitors and ARBs. They will decrease the cardiovascular events, and of course preferred in diabetes and chronic kidney disease, because AC inhibitors or ARBs will affect the GFR, so it could help us to be protective against the proteinuria or nephropathy of diabetes. We have also calcium channel blockers like amlodipine. It's very effective for isolated systolic hypertension. Very effective. And there is something very important, that we should avoid alpha blockers. There's some medications called prazosin, right? So alpha blockers medications, because it will cause severe vasodilation. Alpha blockers in the blood vessels, it will cause vasoconstriction. I know all of you know that. But we should avoid the alpha blockers, because it can lead to severe vasodilation, and at the end, it will lead to hypotension and increase the risk of falls. So we should avoid the alpha blockers. There's something also in the hypertension I want to mention, very important, I can tell you. I said the aggressive lowering of blood pressure increase the fall risk, and it will lead to syncope, sometimes aka acute kidney injury, because the severe hypotension will lead to hypoperfusion to the tissues. And based on the tissue that was hypoperfused, the symptoms will appear. Okay, so for the frail patients, the target blood pressure in elderly fit people, not frail, the target blood pressure will be less than 130/80. If you want me to write it here, less than 130/80. Okay, but for elderly people who are severely frail, the systolic blood pressure could be accepted between 140 till 140. It could be accepted 140, and in some cases still 150. We will avoid the low blood pressure to avoid, of course, the hypotension and the risk of fall. So we have another condition, which is ischemic heart diseases. What I want to mention in the ischemic heart diseases is that elderly people, manifestations of ischemic heart disease is usually not like the adults. Why? Because elderly people will have some neuronal degeneration and autonomic dysfunction. As an aging process, the neurons will start to degenerate. So the feelings or the pain will not be robust or strong as we can find it in adults. I mean, in the elderly, it will not be like the adults. So DIA could be atypical presentation for the ischemic heart diseases. So atypical presentation, it means the elderly people who is very frail could present with some sort of ischemic heart disease, but the presentation will not be like a severe chest pain or the typical presentation. They could present with dyspnea, with fatigability, sometimes confusion. So they could present with a different or atypical presentations, as I mentioned, dyspnea, fatigability, reduced functional capacity, or even the confusion. Of course, they have high morbidity and mortality, and the treatment of the ischemic heart disease will focus only on the symptoms, mainly to relieve the symptoms. And the subtypes, the subtypes of ischemic heart disease, already we know that in the ischemic heart disease, we have subtypes, and the subtypes will help us or will guide us to the treatment. So we have the stable angina itself, and we have something else called acute coronary syndrome. The acute coronary syndrome, all of you know that we have three subtypes: the unstable angina, we have non-ST elevation myocardial infarction, we have ST elevation myocardial infarction. Of course, ST elevation myocardial infarction, this is need immediate intervention, like to do the PCI. The unstable angina, we will see the patient and we will do some scale to stratify the patient. And if he needs PCI or he doesn't need PCI now, it's based on the condition and the patient himself. Okay, so for me, let's go to the next slide to talk about the ischemic heart disease management. So here, the ischemic heart disease management, we can see that statins very important, but patients could receive statins, but statins usually as a treatment, it will be dependent on the patient. How can I say it? The life expectancy. So giving statins for prevention or secondary prevention, it will be affected by the life expectancy of the patient. If he has a good life expectancy, then we can give the statin. If he does not have a good life expectancy, then it will be considered like a polypharmacy, because the benefit from the statins, it will appear after several years. So statins could be used in the treatment of ischemic heart disease, proven mortality and event reduction even in adults more than 75 years. We have the beta blockers. Also, it has been used in the treatment of ischemic heart disease. It will reduce the mortality post myocardial infarction. Also, we will start low to avoid bradycardia or hypotension. We are afraid from that because already elderly people will have like autonomic nervous system degeneration. They can baroreceptors degeneration. They cannot control their blood pressure. We have also the ACE inhibitors and ARBs. They reduce also mortality in patients with left ventricular dysfunction, and it's very good in people who have diabetes and chronic kidney disease, as I said before, because it helped to prevent or to protect in diabetic nephropathy or to treat the diabetic nephropathy or to decrease it. Also, we have the aspirin. Aspirin usually used as a secondary prevention only, not primary prevention. We use it after the onset of the ischemic heart disease. So it could be used in the treatment of ischemic heart disease also. The revascularization, I said that the ischemic heart disease has many classifications. In the acute coronary syndrome, we have the ST elevation myocardial infarction, in which we need to do the PCI or the revascularization therapy. But in elderly people, we will depend on symptoms, on the functional status of the patient, on frailty. If he is mild, moderate, or severe frailty, we will not depend only on the age, because we are not treating an age, we are treating the patient himself. So we can go to the third condition, which is heart failure. I guess I have mentioned before that the heart failure in elderly is most commonly heart failure with preserved ejection fraction, because the most common cardiovascular condition in elderly is the hypertension, and hypertension predisposed to the left ventricular hypertrophy and diastolic dysfunction, and at the end it will lead to the heart failure with preserved ejection fraction. So the aging itself and the hypertension predisposed to the heart failure with preserved ejection fraction. And the heart failure usually in elderly people will be vague. The symptoms will be vague. You can find some edema, you can find fatigability, you can find confusion. So sometimes the symptoms will be vague. And the treatment of the heart failure elderly, we will use some diuretics, of course, like the furosemide, but also we will be very careful because elderly people cannot control their blood pressure. The blood volume cannot be compensated in a good way. So we will be afraid to lose volume. We are afraid from the dehydration, from the electrolyte disturbance and all the things. We should start low and go slow. And of course, because I have mentioned that before, the hypertension was the main risk factor for the development of the heart failure with preserved ejection fraction, and it's a modifiable risk factor. If we control the blood pressure from the beginning, it will help us to prevent the complications or the consequences from the uncontrolled blood pressure. So we should control the blood pressure and the other comorbidities because already those people will have another conditions. There is some medications, sodium glucose transporters too, which called the dapagliflozin and empagliflozin, as I remember. So they could have a benefit. Sometimes they could have a benefit in the cardiac conditions. And of course, we are trying in heart failure to avoid polypharmacy, to avoid drug-drug interaction, and to avoid the maximum side effects from the medications when are combined together. Okay, so I can go to the heart failure management. The heart failure with preserved ejection fraction, which is elderly dominant. We said that because of the hypertension and the aging process itself. The management includes diuretics for congestion, like loop diuretics, which is the furosemide. Of course, the sodium glucose transporter inhibitors like empagliflozin and dapagliflozin. Actually, both of them are renoprotective. They are renoprotective, but mainly the empagliflozin is very good in the cardiac conditions. So it will reduce heart failure hospitalization. It's very useful in that. And also the blood pressure control. As I mentioned, blood pressure or hypertension was the main cause of the high heart failure with preserved ejection fraction. So the control of blood pressure will be as the cornerstone of the treatment. And of course, because the patient is elderly and has only ischemic heart disease or heart failure only, there will be like some other comorbidities. We should optimize the condition of the patient. We should treat the other conditions, like we should modify the obesity. We should treat the diabetes, treat the atrial fibrillation, treat the sleep apnea. So no proven mortality reducing drug except, of course, the sodium glucose transporters like the empagliflozin and dapagliflozin. They have an effect in the mortality, but no other drug in the treatment of heart failure considered to be have like a mortality reduction. We have the heart failure with reduced ejection fraction. This is the other type in which we have systolic dysfunction, not diastolic dysfunction. In this type of heart failure, it's also could be found in elderly, not only the heart failure with preserved ejection fraction, but this one is the dominant. Okay, the other subtype could be found in the elderly patient, and this one could be treated with a different variety of medications. The commonest type cannot be treated by all these medications, but the reduction or heart failure with reduced ejection fraction could be treated with a variety of medications like ACE inhibitors, ARBs, like the angiotensin receptor neprilysin inhibitor, ARNI, which is the sacubitril beta blockers, mineralocorticoid receptor antagonists like the spironolactone, sodium glucose transporter inhibitors, as I mentioned, empagliflozin, dapagliflozin. These have actually a mortality reduction in patients with heart failure with reduced ejection fraction. Also will start low and go slow to avoid hypotension, because hypotension will predispose to the other complications. So I can move to other condition, which is atrial fibrillation. Actually, as I said before, I mentioned something that I have seen many patients recently in the geriatric category. All those patients, or actually like for the patient that I have seen, 50 or 60% of them, they were taking anticoagulant because they have atrial fibrillation, and they was using mainly apixaban because I guess this has a very safe profile, and it's the best one to be used. So it's really very common in elderly people who are more than 65 years old, due to aging process itself, not necessary to have a hypertension. The aging process itself, because the stiffness, the left ventricular hypertrophy, it will affect the left atrium, and there could be like some remodeling in the left atrium, and it will generate foci for the atrial fibrillation. So I have seen a lot of patients with atrial fibrillation, either to have hypertension and other comorbidities, and some of them was having they didn't have hypertension, just the age itself was the cause of the atrial fibrillation. So it's very common in people or in elderly more than 75 years old, often asymptomatic. Of course, the most important complication of the atrial fibrillation is the stroke. That's why they are doing something, they are doing a score, the ChatGPT score. Based on this score, we will say this patient should receive anticoagulation or not. If it was, the score was 2 or more, the patient should receive anticoagulation. We have items inside the score like congestive heart failure, hypertension, age, history of stroke, history of transient ischemic attack, you know, we have a lot of things. So if the patient got 2 points or more, that means they will start to have anticoagulation, or they will start the anticoagulation to prevent the risk of a stroke. And the direct oral anticoagulants are preferred rather than warfarin because warfarin has a lot of side effects or drug-drug interaction or low therapeutic index or many drug-drug interactions. So the direct oral anticoagulants are preferred or favorable than the warfarin. And the management, as I mentioned, the anticoagulation based on the JADS-VASC score. If we got 2 points or more, then the anticoagulation will start. And the direct oral anticoagulant preferred like apixaban, because I told you that I have seen many patients, they were receiving the apixaban. So apixaban, it has the best safety profile. We are focusing on the rate control with low dose beta blockers. We are trying to avoid the excessive bradycardia in elderly people, of course. I am mentioning that a lot, right? So the rhythm control considered only for symptoms and functional limitations. So we are not focusing with rhythm control until there is a severe symptoms or there is functional limitation. And it could be started after the cardioversion. Some medications could be used for the rhythm control like the amiodarone, but it should be avoided as much as we can. We can use amiodarone as a long-term if we don't have any other alternative for the treatment of the symptomatic atrial fibrillation to control the rhythm of symptomatic atrial fibrillation, because it has a lot of side effects. So coming to the, I guess, the last one, the valvular heart diseases in elderly. Actually, the valvular heart disease in elderly, it occurs due to degenerative conditions or degenerative calcific etiology, particularly in the aorta. The aortic stenosis is the most common, and the symptoms appear late. And the treatment depends on the symptoms and the severity of the aortic stenosis. In elderly people in which we cannot do the open heart surgery to repair the valve, we can use something called transcatheter aortic valve implantation. And of course, in the treatment, we should optimize the comorbidities. Elderly people always will have some other comorbidities. We should optimize the other conditions so the outcome will be in a good way. And of course, the management, as I mentioned, the aortic stenosis, we will use the transcatheter aortic valve implantation. This is preferred for patients who are more than 75 years old or high surgical risk. We cannot do the open heart surgery or the valve replacement. And the symptoms onset is a strong indication for valve intervention. Actually, there is no medical therapy to reverse the aortic stenosis. We need to control the comorbidities, and at the end, if the symptoms appear and the patient has a functional decline, we should intervene either with transcatheter aortic valve implantation, or if the patient was fit and was ready for the aortic valve replacement, then we can do that. We have also mitral regurgitation could occur in elderly people. Medical therapy could be used like diuretics, and of course to control the other comorbidities like the blood pressure. We have something also called mitra clip, this for high-risk older adults, which is called transcatheter edge-to-edge repair. The mitra clip is the device, and the transcatheter edge-to-edge repair is the procedure. It's like a minimally invasive procedure used to reduce mitral regurgitation without open heart surgery. And of course, for the aortic regurgitation, we can use vasodilators, ACE inhibitors, ARBs, which will help also in the hypertensive patients. What I want to say from those slides as a take-home message, the cardiovascular diseases in elderly, the risk rises with age, of course, it's non-modifiable risk factor. But modifiable factors still matter. We were talking about the hypertension, we were talking about the diabetes, hyperlipidemia. Presentations are often atypical and silent. As I mentioned, in the ischemic heart disease, sometimes the myocardial infarction will present with functional decline, confusion. Maybe it will not present by the typical presentation of chest pain. Hypertension is the key modifiable risk factor, of course, and heart failure with preserved ejection fraction and atrial fibrillation dominate geriatric cardiology, and treatment must be individualized, not age-based. We will take the patient as whole, not only we are trying aggressively to treat the hypertension or the diabetes. Function, quality of life, and safety, more important than only strict targets. That's why we were talking about the blood pressure targets. We are not treating numbers or age. We should focus on the quality of life of the patient. Of course, we should avoid polypharmacy. As I mentioned, the elderly people will have decreased clearance of the kidney. Their liver will be affected for the metabolism. So we should avoid polypharmacy and drug-drug interaction as possible as we can. So start low and go slow. This is the most important things for the as a conclusion for the previous slides for the cardiovascular diseases. And I guess now I reach it to the end of my presentation. Thank you so much for listening to me. If you have any question, any comment, anything that I could help, don't hesitate. Thank you so much.
Thank you so much, Dr. Rayan, for great presentation. Any questions or any comments?
Thank you.
Any addition from your experience if you see patients with this condition? If not, we can move on to the next topic. Thank you.
Thank you so much, Dr. Nader. Thank you so much, everyone. So the next topic will be presented by my colleague, Dr. Ayah. It's a full guide to writing your literature review. So, Dr. Ayah, if you are ready.
Hello, can you hear me?
Yes, we can hear you, Dr. Ayah. Go ahead.
Okay. Hello, everybody. Thank you very much for this opportunity. Thank you, Dr. Rayan, for the great presentation on cardiovascular disease. I'm gonna share the screen with you in a second. Sorry. So just let me know when you see my screen. Can you see my screen now? Can you guys see my screen?
Yes, Dr. Ayah, we can see it.
Okay. Okay. Thank you very much. Okay. So today, I'm going to talk about how to write your literature review step by step, and the best way to use AI in your literature review. Okay. So before we start, we're going to talk about what is literature review. Literature review is a structured summary and critical analysis of an existing research on a topic. Okay, it is very important because it shows what is already known, what is unknown, and where your research fits. Okay. Also, it shows foundations for theses, dissertation reviews, and original research papers. It's not just for academics. It directly affects clinical decisions and guidelines. Okay. So why it is important to do a literature review? In each research topic, we it's very important and crucial to do a literature review because it prevents duplication of an existing research and also identifies a knowledge gap and also strengthens the study rationale and methodology. Okay. This is generally in any type of research. Let's go to why literature reviews are important in medicine. Okay, so it's because medicine must be evidence-based, okay, and literature review helps us to understand large amounts of research and guide clinical protocols and identify the best treatments and show the gaps where new research is needed. Systematic reviews are often used to write guidelines. Okay. Before we start our literature review, we need to do 3 important steps. We need to define the type of literature review that we are going to write and also identify your audience and also set a clear research questions or objectives. Okay, so define the type of literature review that you are going to write. There are so many types. For example, we have narrative review, okay, which is a general overview written by expert. It's useful for learning, but can be subjective. Okay, it can be subjective because it depends on the person or the expert that writes this type of review. And also we have systematic review, which is a structured, transparent method to answer a specific clinical question. This is the highest level of evidence, and we prefer this type of review in medical research. And then we go to meta-analysis, which is a statistical method that combines results from multiple studies. Often part of systematic review, but not always. Okay. This is the first step, to identify the type of review that we are going to write. The second step is to identify your audience. Are you going to write literature review to publish it in a journal, to present it to your supervisor, for a clinician? It depends. And then set a clear research question or objectives. And this, for me, this is the most important step. Everything starts with a clear question. A poor question leads to too many papers, confusing results, and weak conclusions. A good question is focused, clinically relevant, answerable using published studies. Okay, and then when we decide our research topic, we should agree on timeline to avoid endless searching, because we can find thousands of papers that we need to review in literature. So after identifying the question, we need to set a specific timeline to avoid delays. Okay. Step number 1, define a focused research question. We can use a framework like PICO or PICO when applicable. Okay, PICO helps structured clinical questions. Okay, P stands for patient or population. Who are you studying? And then I for intervention, what type of treatment or exposure that we are looking for. And then C for comparison, to compare to what. And then O for outcome, what outcome matters clinically. For example, does early mobilization reduce ICU length of stay in adult patients? In this example, P, the patient or population is elderly, and then I, the intervention, is early mobilization. And then comparison, we compare the people that were mobilized early to people who were not mobilized early. And then the outcome is reduction of ICU stay. This is the best way to define a focused research question. Okay. And then we come to a new concept is called PROSPRO. PROSPRO is an international online registry for systematic review protocol in health and medicine. Researchers register their review before starting data collection to clearly document their research questions and planned method. This improves transparency and reduces bias and helps prevent unnecessary duplication of systematic review. So before we start data collection for our systematic review, and after we defined our research topic, we go and register it on the PROSPRO. You do not upload your review results. We do not upload the results. We only register the question and the type, and then the database that you search, inclusion and exclusion criteria, and the outcomes you will study. Is PROSPRO mandatory for every single literature review? The answer is no. It's not mandatory, but it is strongly recommended. Why? Because it is often expected for medical systematic review from journals. If you're aiming to publish in a really good journal, they expect you to register your literature review in a PROSPRO, but it's not mandatory. Okay, so step number 1, we defined a research topic, and step number 2, smart literature search. We start searching. We can search using key database that we all know, PubMed, Scopus, Web of Science, Google Scholar, and combine the keywords, for example, and, or not, and then apply filters carefully depending on what we are looking for, date, language, and study type, and missing studies can change conclusions. So we need to include every single study that is important in our topic. Step number 3, screen and select article efficiently. Okay, so how can we screen and select the articles efficiently? We start with titles and abstract. Okay. Exclude irrelevant or low quality studies early, and then prioritize recent and high impact and guideline papers, and then use reference list to find key missing articles. This is a very important step because we might find thousands and hundreds of papers in the specific topic, and we need to include only the topics that are recent high impact guidelines paper, and then exclude any irrelevant low quality studies. Step number 4, organize the literature. Okay, we can organize them by theme, methodology, or outcome. Okay, create summary table. We can use, for example, Excel, Google Sheet, whatever, and then we summarize every single paper that we went through in our review, based on authors, study design, number of patients, outcomes, results, years, methods, and findings for data extraction. This helps us to avoid mistakes and repetition. Okay, it is always preferred to use reference managers like Zotero, Mendeley, or EndNote. Good organization reduces time by half because literature review is very time consuming. So the more organized, the less time that we spend on them. And then step number 5, critical appraisal. And here we come to writing. It's called synthesis. Synthesis means combining findings from different studies, explaining similarities and differences. You can do narrative synthesis, which we only write, and the meta-analysis, which based on statistical results, numbers from the papers that we went through. And then we compare results, identify agreements and disagreements, and highlight strengths and weaknesses. How to structure the literature review. Okay, we have a really good way to structure our literature review. It's called Prisma. Prisma is preferred reporting items for systematic review and meta-analysis. It is specifically used for systematic review and meta-analysis. Not all type of literature review uses this Prisma method. It provides a checklist and flow diagram to ensure that reviews are reported clearly, completely, and transparently. Okay, the checklist includes title, abstract, method, results, discussion. Okay, this is to ensure nothing important is missing. So finally, I'm going to give you practical tips. Write section by section, not paper by paper. For example, we go through all the abstracts and then we go through all introductions, we go through all methodologies rather than going paper by paper. And this will help us to reduce the time on writing our literature and make paragraphs look more organized and flow smoothly. Okay, and then use topic sentences to guide each paragraph. Topic sentence to tell the reader that this paragraph is going to talk about, for example, introduction. The second paragraph is going to talk about the methods that we used, and then so on. Paraphrase instead of quoting, and this is very important in scientific writing. It's a very important skill. And then edit for clarity and conciseness after drafting. Okay, so now we're going to talk about how to use AI wisely in our literature review. Okay, AI is a very important tool, and it reduces the time and help us understand a lot. Use AI for we can use it for brainstorming, outlining, and simplifying concepts. We can ask the AI to summarize paper you've already read, okay? You have already read that paper, but you want it to be summarized. You can ask the AI to help you with that. Use AI to improve language, clarity, and flow. It cannot write your literature review, but after you write it, you can go and use the AI to improve the language and clarity. Never use AI as a substitute for reading original articles. It can never be a substitute. You, the researcher, should read all the articles. You should write your own literature review, and then AI tools could be a help or assistant in the end after you finish. Common mistakes that people do when they use AI. Please do not use AI to create new data. Only use the data that you found in your literature. You cannot use AI to replace reading. You have to go through all these articles by yourselves, but you can use it to summarize the main concepts in that article. That's fine. And then you can never make decisions based on AI. Researcher remain the main responsible. Okay. And then there are a few frequent mistakes that new researchers do in their literature review. First of all, poor question, because clear questions is the base and the most important step in making a good literature review. So poor question would be a very frequent mistake. Incomplete search, which means we did not include all possible papers and articles that we can use in our literature. Ignoring bias and overstating conclusions. So good methodology is more important than exciting results. In literature review, we're not looking for exciting results. We're only looking for a good methodology, a very good and honest methodology. And finally, key take-home message. Good planning makes writing fast and efficient. AI is a tool and is not an author. Strong reviews lead to strong research. Thank you. If you have any question or concern, feel free.
Thank you so much, Dr. Ayah, for the clear and structured overview of the literature review writing. Thank you so much.
Thank you.
If there is any question, everyone. Okay. Okay. If we have no question, we can move to the next topic. I would like to invite Dr. Malaz to discuss the role of humanoid technology and its potential impact on modern practice. So, Dr. Malaz.
Yes, can you hear me well?
Okay. We can hear you, Dr. Malaz.
Okay, first let me to share the presentation.
Dr. Malaz, could you please raise your voice?
Can you hear me well?
Yes, we can hear you now. Thank you so much.
Okay. Can you see my screen well?
Yes, Dr. Malaz, we can see your screen. It's very obvious and nice.
Okay. Good evening, everyone. I'm Dr. Malaz Salah, and it's my pleasure to have this opportunity to speak with you today. And today I will present the humanoid and the future of clinical practice for the IMGs in the United States. I want you to imagine this moment with me. It's your first week as an international medical graduate in United States hospital. You have studied hard. You have passed difficult exams. You are clinically competent, but suddenly you find yourself surrounded by systems you were never formally trained in: electronic health records, automated workflows, new communication expectations, and then you notice something unexpected: a humanoid robot guiding patients in the hallway. At that moment, the question is no longer, am I a good doctor? The real question becomes, am I prepared for this system? And this is exactly why I choose to talk about humanoids today. As an IMG myself, I realize that our biggest challenge is not knowledge, it's adaptation. We are entering healthcare systems that are evolving faster than traditional training. Humanoids are not a futuristic idea. They are already present in hospitals, quietly supporting care delivery. And if we do not understand how these systems work, we risk feeling lost even when we are clinically strong. So today I'm speaking to you as an IMG, talking to the other IMGs. We will explore what humanoids are, the different types used in healthcare, why hospitals are adopting them, and how understanding this can actually help us integrate better, perform better, and stand out in modern clinical environments. And this is naturally leads us to the first questions we need to answer together. Why do IMGs need to know about humanoids in the first place? As we know, healthcare systems in the United States are becoming increasingly complex. It is no longer just about seeing patients and making clinical decisions. Clinical practice today happens inside highly structured systems that rely on technology to function efficiently. Actually, many of the challenges we hear about burnout, time pressure, and reduced patient interaction are not due to lack of clinical knowledge. They are system-level challenges, and this is exactly where humanoids come in. Humanoids are introduced as support tools to help healthcare systems manage volume, standardize processes, and maintain consistent patient engagement. They are designed to take over repetitive, non-decision-based tasks, not to replace clinicians, but to protect clinician time and focus. And from our perspective as IMGs, this matters deeply. As IMGs, we often enter US hospitals with a strong medical knowledge, but limited exposure to these systems-driven workflows. So when we understand how humanoids fit into these systems, we reduce uncertainty, we communicate more confidently, and we integrate faster. More importantly, programs and supervisors are not just evaluating what we know, they are observing how we function within the system. When we demonstrate awareness of emerging technologies like humanoid, we show adaptability. And adaptability in modern healthcare is a core clinical skill. And this naturally leads us to the next question. What exactly are humanoid robots in healthcare? When we say humanoid robots, we are not simply talking about machines that look like humans. Actually, what defines a humanoid in healthcare is not the shape, it's the function. Humanoid robots are systems designed to interact with humans in a human-like way. They are equipped with artificial intelligence, speech recognition, sensors, and controlled movement. But more importantly, they are designed to communicate. As we know, healthcare is built on interaction. We ask questions, we explain, we reassure, we guide. So when a robot is designed specifically to listen, respond, and engage in these interactions, it becomes clinically relevant. Another critical point is where these humanoids operate. They do not stay in labs or behind screens. They function in patient-facing environments, clinics, wards, waiting areas, rehabilitation units. And this is exactly why they matter in real clinical practice. However, it's important to clarify something very clearly. Humanoid robots do not diagnose, they do not prescribe, and they do not make ethical or clinical decisions. Their role is supportive. They extend care processes, standardize communication, and reduce workload, while clinical responsibility remains entirely human. So the key question now becomes, are all humanoids the same? Are all humanoids the same? And the answer is clearly no. Actually, humanoid robots in healthcare are designed for different purposes, depending on which part of healthcare system they are meant to support. And as we know, healthcare is not one single process. It starts from patient entry, continuous through care and follow-up, and also involves staff workflow behind the scenes. So in clinical practice, we can broadly classify humanoids into 4 main types. These types are patient interaction humanoids, rehabilitation and engagement humanoids, companion and continuity humanoids, and workflow and staff support humanoids. Each type supports a different stage of care. And to make this clearer, I will go through each type separately with a real example for each one. So let's start with the first type, the one patients usually see first, which is a patient interaction humanoid. A well-known example of this type is Pepper. Pepper is a fully humanoid robot designed mainly for communication. As we know, the patient journey begins before any doctor sees the patient. Patients arrive confused, anxious, and unsure where to go. This is where Pepper is used. Pepper is usually placed at hospital entrance or outpatient areas. It grades patients, gives directions, explains basic procedures, and answers common questions. By doing this, People reduce anxiety and confusion. And when patients are calmer, the whole system works better. Staff face fewer interruptions, and clinicians can focus on medical care. Once a patient moves beyond the front desk, care becomes ongoing, and this leads us to the second type, which is rehabilitations and engagement humanoids. A common example is Now. Now is a semi-humanoid robot, is smaller in size but highly interactive. As we know, rehabilitation depends heavily on repetition and motivation. Patients often know what exercise to do, but struggle to stay consistent. Now helps by demonstrating exercise, encouraging patients, and supporting repeated sessions. It does not replace therapists. Clinical decisions and safety remain entirely human. Now simply supports motivation and engagement. But we know healthcare is not only about therapy sessions, it's also about continuity of care. And the third type focuses on continuity and ongoing interaction. An example of this type is Grace. Grace is a fully humanoid robot designed to support regular communications with patients. It can assist with reminders, basic check-ins, and ongoing interactions. As we know, trust in healthcare is built through consistency. In long-term care or sitting with limited staff, Grace helps maintaining that sense of continuity. It does not replace clinicians. It reinforces the care plan and supports patient engagement. And the final type, however, does not focus on patients at all. The first type is workflow and staff support humanoids. A well-known example is Moxie. Moxie is a semi-humanoid robot designed mainly for functional tasks. It supports healthcare team by delivering supplies and handling routine logistical tasks. By doing this, most reduce interruption. And so we know, and as we know, fewer interruptions means better focus, fewer errors, and safer patient care. So now we have seen the different types of humanoid and how each one supports a specific part of care. And the next logical question is a very simple. Why are hospitals actually adopting humanoids? As we know, healthcare systems today are under enormous pressures. There are staff shortages, increasing patient volumes, and a growing administrative burden. Actually, many of these challenges are not clinical problems, they are system problems. Humanoids are being adopted to address exactly these system-level challenges. First, they help compensate for workforce shortage by taking over repetitive, non-decision-based tasks. This does not replace clinicians, it protects clinician time. Second, humanoids support consistency. They deliver the same information, the same reminders, and the same guidance every time. And as we know, consistency in healthcare improves safety, efficiency, and patient trust. Third, humanoids offer availability. Healthcare operates 24 hours, but humans experience fatigue. Humanoids do not get tired, distracted, or overwhelmed. They provide continuous support without burnout. And finally, humanoids improve workflow by reducing interruptions, minimizing delays, and standardizing routine interactions. They allow healthcare teams to focus on what truly matters, which is the patient care. So hospitals are not adopting humanoids because they want more technology. They are adopting them because they want better systems. And once we understand these motivations, it becomes much easier to see where humanoids fit inside the patient journey. So let's take a closer look at how humanoids support care at a very visit point of contact, which is the front door of healthcare. So support at the front door, which is meaning, in the other words, how does all of this actually translate into daily clinical practice? And the most logical place to start is the very beginning of the patient journey, the front door of the healthcare. As we know, the first interaction a patient has with a healthcare facility sets the tone for entire experience. Patients often arrive anxious, confused, and unsure where to go, and is and in a large hospital, this confusion can quickly lead to delays, frustrations, and repeated interruptions for staff. This is exactly where humanoids are commonly introduced. At the front door, humanoids support patient intake and navigation. They grade patients, guide them through registration steps, collect basic non-clinical information, and direct them to the correct department. Now, this may seem like a simple rule, but actually it has a significant system-level impact. When patients are oriented early, patient flow improves, waiting times decrease, and staff experience fewer interruptions. And as we know, when the front door functions smoothly, everything downstream in the healthcare system functions better. And clinicians can start their encounter on time. Patients arrive calmer and better prepared. So this is a clear example of how humanoids are applied in real clinical environments, not as a replacement, but as a workflow support tools. So the next question is, what happens after the patients enter the system? As we know, healthcare does not end at registrations or the first clinical encounter. A large part of care happens through daily routines, monitoring, reminders, follow-up. And this is exactly where the next application of humanoid comes in. Humanoid can support monitoring and daily checks. They assist with medication reminders, schedule vital signs checks, and routine follow-up interactions. Now, it's important to be very clear here. These humanoids are not diagnosing. They are not interpreting clinical data. They are supporting structure and consistency. As we know, one of the biggest challenges in healthcare is adherence. Patients often understand the plan, but struggle to follow it consistently. Daily reminders and structured check-ins can make a significant difference. And when adherence improves, outcome improves, complication decrease, and the burden on healthcare teams is reduced. So in these applications, humanoids act as a bridge between the care plan and the patient's daily behavior. They reinforce instructions without replacing human judgment. Okay, what about situations where care requires physical guidance and repetition, not just reminders? And this leads us directly to the role of humanoids in physical therapy and rehabilitation. And as we know, rehabilitation and engagement, humanoids focus on motivation, repetition, and patient participation, not on diagnosis or clinical decision making. And this is why they are particularly effective in physical therapy. In rehabilitation, consistency is critical. Patients may understand the exercise, but maintaining motivation over time is often the real challenge. This is where this type of humanoid becomes useful. These humanoids can demonstrate exercise, sorry. Sorry. In rehabilitation, consistency is critical, as we know, and patients may understand the exercise, but maintaining motivations over time is often the real challenge. This is where this type of humanoid becomes useful. This can demonstrate exercises step by step, repeat movements without fatigue, and coach patients through sessions in a calm and encouraging way. They provide structure and engagement while the clinician remains fully responsible for assessment, safety, and treatment plan. As we discussed earlier, the humanoid support engagement, not judgment. And by reinforcing repetition and motivation, adherence improve. And as we know, when adherence improves, rehabilitation outcomes improve as well. And once we see this type support physical recovery, sorry. Let's see a move how the humanoid enhancing medical education. If humanoid can support patients so effectively, they also support us as clinicians? And these questions take us directly into medical education. As we know, medical education is not just about learning facts. It's about learning how to think, how to communicate, and how to perform confidently in real clinical environment. This is where humanoids start to play a different but equally important role. In training settings, humanoids can be used in simulation-based education. They allow repeated practice of clinical scenarios. They allow trainees to practice communications, explanation, and decision making without the pressure of real patient harm. And for IMGs, this becomes especially powerful. As IMGs, one of our biggest challenges is not intelligence or medical knowledge, it's confidence within a new system. It's learning how to function, communicate, and present ourselves in unfamiliar clinical environment. And humanoids provide a structure and supportive space for that transitions. They do not judge and they do not rush. They allow repetition. So at this stage, humanoids move from being patient support tools to becoming clinician preparation tools. And we know once clinicians are better prepared through training, the next questions became very practical. How does this preparations actually show up in real clinical practice? And the answer is definitely through communication. As we know, communication is a core clinical skill in US healthcare. It's not only about what we know medically, it's about how we explain, how we listen, and how we build support with patients. For IMGs, this is often one of the most challenging transitions, not because we lack empathy or knowledge, but because communication styles, expectations, and patient involvement can be very different. This is where humanoids used in trading and simulations become especially valuable. They allow us to practice patient-centered communication. They allow us to raise difficult conversations, and they allow us to receive feedback in a structured and safe environment. By repeatedly practicing these interactions, clinicians become more confident, and confidence changes everything. It improves patient trust, it improves clarity, and it reduces misunderstandings. So what we see here is a clear progression. Humanoids support training, training improves communication, and communication directly impacts patients' outcomes. And once communications improves, the final impact becomes clear. So what happens to the clinicians when the system supports communications and workflow effectively? And this is leads us to clinician burden and burnout. Right. Okay, I'm sorry. Before talking about clinician burnout, let us see humanoids, how it supports hands-on training. As we know, clinical competence is not built by theory alone. It's built through practice, guided practice, and repeated practice. This is where humanoids play a very powerful role in hands-on training. They can provide step-by-step guidance, helping trainees follow procedures in a structured and safe way. They can offer sensor-based feedback, allowing learners to understand exactly where adjustments are needed. And most importantly, they allow unlimited practice. This means clinicians can practice a skill repeatedly without risk to real patients. They can build confidence gradually and they can adopt new systems at their own pace. For IMDs, this is especially important. It creates a safe bridge between prior training and new clinical expectations. And once clinicians are trained and prepared, I'm sorry, I have an asthma attack. So
You're doing good.
So let's see how the humanoid is supported in documentation and workflow. As you know, modern healthcare relies heavily on documentation and workflow, chart entry, scheduling, medication reminders. These tasks are essential, but they are also one of the biggest contributors to clinician overload. This is where humanoids support documentation and workflow. They assist with routine chart-related processes, they help organize scheduling, and they support medication reminders. It's important to be very clear. Humanoids are not making clinical decisions. They are not replacing clinical judgment, and but they are supporting the process, not the thinking. And by supporting these processes, workflow becomes smoother, delays decreased, missed steps become less frequent, and interruptions are reduced. And when workflow is supported effectively, the impact becomes very clear. Okay, so let us see how the humanoid reducing the clinician's burden. As we know, burnout in healthcare is not caused by lack of dedication. It's caused by overload, constant interruptions, and administrative pressure. When humanoids offload repetitive tasks and support workflow continuity, they remove a layer of friction from daily clinical work. They do not replace clinicians, they do not make decisions, but they allow clinicians to focus on higher level care. When interruption decreases, focus improves. When focus improves, decision making improves. And when decision making improves, patient safety improves. So reducing clinician burden is not about working less. It's not about working less, it's about working better. And when clinicians are supported and less overwhelmed, the effect is not limited to
على
the
system
healthcare
ماما
team. So the
Sorry.
impact extends directly to the patient. So let's see how the humanoids improving patient experience. And we know when clinicians are less burdened, patients feel the difference. As we know, patient experience is built on clarity, trust, and consistency. When humanoids support reminders, follow-up, and communication, patients feel less confused and more supported. Friendly reminders reduce missed medications. Consistent follow-up improves adherence. And language support helps patients feel understood. This is especially important for elderly patients, patients with chronic conditions, and patients facing language barriers. Patients understand their care plans, anxiety decreases. When anxiety decreases, cooperation improves. And when cooperation improves, outcomes improve definitely. So improving patient experience is not just a service benefit, it's a clinical benefit. And this completes a full cycle from training clinicians to supporting workflow to reducing burden and ultimately to improve patient care. So what about new career? So at this stage, it's natural to ask an important question. What does all of this mean for us as clinicians? And more specifically, what does it mean for us as IMDs? As healthcare system evolves, they do not just change tools, they change expectation. Today, hospitals are not only looking for clinically competent doctors, they are looking for doctors who understand systems, doctors who can work confidently within technology integrated environments. This is where humanoids create new career advantages. IMGs who understand how humanoids fit into clinical workflows can lead tech integrated teams. They can engage in innovation and robotics related research, and they can stand out during interviews, not because they talk about robots, but because they demonstrate insights, adaptability, and future readiness. So instead of being seen as doctors trying to catch up, IMGs can position themselves as doctors ready to move healthcare forward. But as we talk about opportunity, it's equally important to talk about limits. What can humanoids support and what can they never replace? This slide is one of the most important slides in the entire presentation because it defines a boundary. As advanced as humanoids are, they have clear limitations. They lack emotional nuance, they rely on logical patterns, and they operate within predictable frameworks. Humanoids can process information, but they do not truly feel. And this is where human strengths remain irreplaceable. Empathy and compassion, critical thinking in complex and uncertain situations, and cultural intuition. These are not programmable skills. They are developed through life experience. So the goal of humanoids is not to replace clinicians, it is to support them. Technology handles the structure and humanoids handle meaning. And once we understand this balance, we will go through the next question, which is how do we integrate humanoids responsibly into healthcare? As humanoids become more present in healthcare, responsibility becomes central. Responsible integration is not optional, it's essential. First, privacy and data protection must be prioritized. Patients need to trust that their information is safe. Second, cultural sensitivity matters. Healthcare does not exist in vacuum. It exists within social and cultural contexts. Third, patient trust must always come first. Technology should strengthen trust, not weaken it. And finally, accountability must remain human. Clinicians are responsible for decisions, system support, but humans remain accountable. When these principles are respected, humanoids become safe, ethical partners in care. And once we integrate them responsibly, we can look we can look ahead what the futures actually look like. When we look forward 2030, the future of healthcare becomes clearer. We are moving toward hybrid clinical teams where humans and humanoids work side by side. Humanoids would expand beyond hospitals into homes and community settings, supporting long-term care and chronic disease management. And importantly, AI-assisted training will become more accessible for IMGs. This means learning will be more personalized, practice will be safer, and adaptation to new systems will be faster. So the future is not about choosing between humans and technology. It's about collaboration. And for IMGs, these futures represent opportunity, not threat. So preparing as an IMG. At this point, a very practical question comes up. If this is the direction healthcare, if this the direction of healthcare is moving toward, how do we prepare ourselves as IMGs? And the answer is not complicated. It is strategic. The first step is building basic tech literacy, not to become engineers, but to feel comfortable working with the digital and AI supporting system. The second step is understanding AI basics, not how to code, but how AI supports clinical workflow, decision supports, and training. The third step is exposure, joining robotics, simulation, or AI-assisted training whenever possible. This builds confidence and familiarity. And finally, we need to highlight these skills in interviews, in applications, and in conversations. Because when an IMG can clearly explain how they adapt to modern healthcare systems, they do not just sound competent, they sound prepared. And this leads us to the final message of this presentation. Just I want to say this presentation is not about robots, it's about us. It's about how we practice medicine, how we train, and how we adapt. Humanoids are not replacing us. Humanoids are not replacing empathy. They are not replacing judgment. They are supporting what we already do. They take care of repetitions. They take care of structure. They take care of consistency, so that we as clinicians can focus on what truly matters, listening to patients, understanding complexity, and making human decisions. For us as IMGs, this is not a trade. This is an opportunity to enter healthcare systems that are evolving, to position ourselves as adaptable, future-ready clinicians, and to show that we are not just catching up, we are contributing. And the future of healthcare is not human versus technology, it's human with technology. And compassion will always remain at the center. And us, IMG, we are not behind this future, we are a part of it. And thank you so much.
Thank you so much, Dr. Malaz.
Thank you so much, Dr. Malaz, for a great presentation. Any addition or any questions to Dr. Malaz or any comments? Thank you.
Yes, I do have one question.
Go ahead.
Is this like a look into the future, or is this an actual thing in the US? Because here in Saudi, we still don't, I've never seen a humanoid in the hospital. So is that a thing in the US?
Anyone to comment? So I haven't seen it in, I live in a small city here in Lansing, Michigan. I haven't seen it, but I assume it's gonna be used, or it's already used in big cities or big centers like Mass General Hospital, hospitals related to Harvard University, Yale University, or even here in the University of Michigan, for example. I'm gonna share with you screen here. It's a brief video. So I don't think it has the sound, but if you can hear, that's fine. So I hope that answered your question, Dr. Jay.
Yes, it does. Thank you.
So thank you, everyone. Thank you, Dr. Malaz, for highlighting the future-oriented role of humanoid technology in healthcare. Another rapidly evolving area in the use of artificial intelligence in daily clinical and academic work. So to demonstrate this in a practical way, I'm also pleased to invite Dr. Lojaine. She will present a hands-on tutorial on using ChatGPT effectively in medical practice and education. Are you ready, Dr. Lojaine?
Yes, I am sharing my screen right now. Okay, can everybody see? So today I'll be presenting a topic in which everybody knows about ChatGPT and how we can put into our daily practice as doctors. So ChatGPT, for an introduction, ChatGPT can help doctor with research, patient education, clinical decision making, and administrative tasks. These prompts can help the efficiency, accuracy, and decision making in daily medical practice. So my first example for this would be a prompt for diagnostic assistance. So here I wrote for ChatGPT is to provide me a differential diagnosis with explanation for the most likely condition. In this way, it can help doctors generate. Hold up. Oh, sorry for that. I don't know what happened. Anyways, yeah. So it can help generate a range of potential diagnosis and improve diagnostic accuracy. And it also saves time by offering a structured list that can prioritize the most common and concerning conditions. So for example, I have here in ChatGPT, I already wrote it down to save time. So I asked it, give me the following, given the following patient symptoms, I have fever, cough, shortness of breath, and provide a differential diagnosis with explanations for the most likely condition and prioritize condition based on the likelihood and severity, including the relevant diagnostic test or workup that should be performed. So here it gave me, I believe, 10 different differential diagnoses. Okay, 11 with its explanation as to why did it put it there, as well as diagnostic tests. So here we have pneumonia being the first, with bronchitis, COVID-19, pulmonary embolism, congenital heart failure, COPD, tuberculosis, pneumothorax, asthma, and interstitial lung disease, as well as lung cancer. As well, underneath here gives you a quick brief summary of prioritization as well, just so you can use it as a brainstorming kind of thing. So this allows you to save time or to see just in case you're missing something and you want to see. So you can use ChatGPT using that prompt. And then you have for the prompt number 2, you can use it for medication dosage and guidelines. So you can just write, what are the current dosage guidelines for medication? Or okay, you can use any type of medication, like amoxicillin, say, in treating a certain condition for a specific age group. So here is a practical example for that. I wrote here, I believe, amoxicillin, right, in treating a highlighted bacterial pneumonia, and to include adjustments for renal or hepatic impairment. And as well, I said for adults, like how does it look like? So ChatGPT gives me a really nice guideline. It's brief and it gives you all its dosages, whether thrice daily or twice a day. So here with its duration as well. So, and it also gives me what to do in case there's hepatic impairment. Here it said, it is not extensively hepatically cleared, right? So ChatGPT can be used with that, as well as contraindications and special considerations. So yeah, so in this way, ChatGPT can help reduce errors in healthcare, as well as this prompt ensures that the doctors are up to date with evidence-based dosing information. I believe there's also in ChatGPT you can ask it to go through to do a deep research. You can plug it and you can say do a deep research, but I don't think I have it because I don't have the paid version. So here it is. So you can say do me a research about amoxicillin and renal adjustments for those with renal impairments, where it can give you, well, it's going to ask you to give exactly what you want, so it can be precise. So other than that, you can use another prompt, such as patient education. I actually got this idea from Dr. Nadir's research project assignment, in which we had like just a few days ago, in which it was about the dementia, the use of complex terms in dementia and how to explain it to their family member, in which we plugged it into ChatGPT with a certain prompt to simplify the words or to simplify the language. So here I wrote, you can write in the prompt as explain, let's say dementia, in a simple term suitable for a patient with no medical background. So ChatGPT, I wrote here, was about diabetes 2 mellitus, in which ChatGPT simplifies it and even gives me a simple, and it even breaks it down to a simple analogy as like how it works under if the body was a car and the gas was glucose. So ChatGPT is actually really good at that and breaking down medical complexities for patients. So here is an example for it, in which I asked ChatGPT to explain type 2 diabetes in simple terms, suitable for patients with no medical background, providing clear examples and analogies that will aid understanding and make sure to address common questions and misconceptions. So here it is, where ChatGPT had explained what exactly type 2 diabetes with breaking it down as well, in case, so that the patient can conceptualize it in a simple manner, and then everything is broken down into simple terms, as well as how to manage and hear. So Chat GPT gives you a really good answer for that. So we also have prompt number 4, in which we can use it in evidence-based recommendations. So the prompt is summarize the latest evidence on conditions or treatments, including recent clinical trials and guidelines, right? So over here, I asked the same exact thing, but but in regards to hypertension, in which I told ChatGPT to show me anything with in regards to recent trial, meta-analysis, or updated guidelines, so that you can always be updated with the new guidelines to hypertension as well. Here, ChatGPT gives us from American Heart Association and gives us the link as well. So we can be updated. Here we go. With ChatGPT also makes sure to link every essential, here it is, every essential site for it as well for reference. But I don't believe that this is available on the free version of ChatGPT, so please take note with that. So yeah, here we go, in which you have American Heart Association, in which it tells you the 2025 high blood pressure. So this is really easy and simple. Like example, for say you're in a hospital and you wanted an updated breakdown, so ChatGPT can give you a really good rundown. So here, with its importance is that it keeps doctor updated with the most recent evidence, which is crucial for making informed treatment decisions. And then we have prompt number 5, which is clinical protocol summaries, in which you can just ask ChatGPT to provide a detailed summary of the clinical protocol for managing a certain condition, including diagnostic steps, treatment options, and follow-up care. So you can just copy and paste this as well, but ask about a certain condition. So here I asked about acute ischemic stroke, in which it gave me exactly what I wanted. But the most important part about ChatGPT is your prompt engineering. It's how you do the prompt. You want it to be as precise as possible. So here I asked it exactly what I wanted. I wanted diagnostic criteria. I wanted treatment options. So and recommended follow-up care. So here it is. It gives me exactly what I want to see. So we have the diagnostic criteria for acute ischemic stroke, as well as how to initially recognize it and its immediate diagnostics, as well as acute treatment options, supportive and adjunct care, its follow-up care, and a summary. Another prompt that we should see, right? So the importance of that prompt of the clinical protocol summaries is that it streamlines the process of looking up comprehensive clinical guidelines and protocols. And it's just, and overall, just reduces like the complicated management plans, and just gives you a good summary in case you're in a hurry and you just had to make sure Prompt number 6 is actually a really good way as well, like in which you can use medical ethics and decision making. Sometimes there are complex ethical debacles in the US that, they're really strict with. So yeah, so you can go to check ChatGPT as well as an IMG. I guess it's really important as well because it's a new land, it's something that is new. So you have to get used to the law as well. So here you can ask ChatGPT also to provide you a guidance on medical ethics in which situations where a certain ethical dilemma arises, considering patient autonomy, beneficence, and justice. Here, I said the exact same thing in which I've asked how to initiate life-sustaining treatment in a patient with advanced Alzheimer's disease who has no advance directive. Advance directive is a really, really important, medical legal situation in the US. So if you're new to the land as an IMG and you don't exactly know, you can even ask ChatGPT in which you can also ask it to do a deep research, or like you can ask it for, I guess, like you can see exactly what's going on, in which ChatGPT also gives me exactly what I asked for. So it tells you about patient autonomy. It gives you a brief rundown. So it tells you about the patient autonomy exactly. So what to do, but what are the challenges in the cases? What are the ethical approaches? And the beneficence, what are the challenges in the cases? And it's all as I asked in the prompt. So yeah. And then we have the 7th prompt, which is in this almost the same topic as what Ayah mentioned earlier. You can use it in literature search for research. So we can just ask ChatGPT to find me the most recent studies on a particular subject, right? And summarize their key findings. So here I have asked ChatGPT to say that I'm really interested in CRISPR-Cas9, right? And I've asked it to give me the most recent studies in the past 5 years because I want to do a meta-analysis on it. And it gives me exactly as that here. They've spoken about Excel and given me the PubMed link in which I can automatically open the thing, and it saves time and shows you exactly what you can write about for later on. So you can use it for reading. As Dr. I mentioned earlier, it's important that you do a rundown of what you are doing literature and not put the job directly at AI. So here it gave me the research, and yeah, it saves a lot of time. So its importance is that it simplifies the literature review process, enabling doctors to stay current in their field and enhance research efficiency. So yeah, in conclusion, ChatGPT is a powerful tool for clinicians, enhancing patient care, administrative efficiency, and professional development. Mastering these prompts can save time, improve outcomes, and enhance the quality of healthcare. Meanwhile, if anyone wants to copy and paste or like get the prompt, can just give me a message. Other than that, I think you can write it, but be sure to be very specific about what you want from ChatGPT, as sometimes it cannot give you the result as you want, and so you waste time, pushing and pulling with ChatGPT as to what you want. So I want you to be very precise with what you want to write, and yeah, and you can also ask it even to give you articles so that you can also double check what you're searching for. So yeah, thank you for listening. I'm done.
Another great presentation. Thank you so much, Dr. Lojaine. I sent a link, sorry, a chat. So if you can, in the meantime, Dr. Lojaine, use that and modify it the way you want this patient scenario. You can put the setting, let's say in a nursing home, in a clinic, or in a hospital, and then show us how this is done. I'm sharing with you this because I see patients in nursing homes who are adults with multiple comorbid conditions, let's say patient with dementia and diabetes. So I will leave you alone for now. Lojaine, you can take it from here. Just show us how it's done. Thank you.
Okay. Doctor, I did not see the link. Okay, so here we have, so we can just copy paste this as well. Okay, so Dr. Nader has mentioned that some of the elderly patients have a hard time writing or like understanding, I believe, Dr. Nader, the medication, or how is it? Should I write the progress note? So yeah, so we can just plug into ChatGPT to help us simplify this. So right now we have here an 81-year-old female patient with major depressive with diabetes type 2, hypertension, and hyperlipidemia, I believe. She's given Lexapro oral tablet with 10 milligrams, as well as Lipitor oral tablet with Aricept oral tablet with Norvasc and Namenda oral tablet with Kozar. Okay, so right now we will ask ChatGPT to write us a progress note plan. Okay, and excuse me, Dr. Nade, do you want me to just ask ChatGPT to write a progress note plan and to simplify these for the patient to understand, or how exactly?
No, just to help you understand how to write the progress note, along with some suggestion for the patient or the physician to make changes if required. Like if the, oh, sorry, I have to add also blood sugars. Sorry.
Okay.
Okay, I forgot to give you that. So let me give you that in the chat if I can find it. I put it in the chat. So if you can just tell to analyze the blood sugars.
Yes.
Thank you. So basically at the hospital, they give you a list of vitals in a setting like nursing home. They keep the record for blood sugars, or if you want to, you can also ask your patient in the clinic to bring their blood sugar reading or blood pressure readings, and then you can put it in a prompt like what Dr. Lojaine is doing, and then you can analyze that. So basically, one of the things it will do, it will analyze the blood sugars, which one is the highest number, the lowest number, the mean, the time during the day, most likely after. So here you go.
Oh, wait, I think I should make it in a new page actually. So as to not confuse.
Okay, yeah, it's true.
Yeah. Started to hallucinate.
Yep.
So yeah, so be aware with that. You guys should read it just in case it hallucinates and doesn't give you exactly what you want. So here I've asked it to make me, actually I've asked it to make me a tab table, actually. So yeah. So yeah, so it gave me a progress note with exactly how you have an 81-year-old female here. His past medical history is dementia with major depressive disorder, with type 2 diabetes mellitus, with hypertension, hyperlipidemia, with her medications as well. And here, and the reason for review with the subjective, we have the patient has dementia and is unable to reliably report the symptoms. So here as well, and it gives us the objective exactly, so we can see the lowest values and compare. And so yeah, so we have, it gave me a summary though, instead of the actual thing, instead of putting it in a table. So yeah, so it just
it's
gave
the
me a
summary
summarized.
table. Yeah, yeah.
It
You
just
can
gave me a.
elaborate. You can
I can
elaborate.
elaborate. But Dr. Nader,
can-
I'm using the free version, so that's why it's actually
No,
like.
it will. If you want, you can add more to whatever elaboration you want. If you want
Yes,
to
yes.
get. So here in the table, that the summary table, it shows you the time during the morning, what's
Yes, yes.
the range and the average, and then during the night or evening. So basically, it shows you during the day, morning time, the blood sugars are very well controlled, but during the evening time, it's not well controlled. So there might be a reason there. Or maybe you want to change some of the medication to address the evening dose, for example. So go down to the
It actually
assessment
gives you
plan.
assessment as well and a
Yeah.
plan.
Yes.
So here we go. And tells you glycemic targets. And a caregiver education. Yeah. Do I ask it to give us a precise, accurate table?
No. See what the guidelines for this patient are they met for this patient per common guidelines for patients with diabetes.
Do I ask it? Are the guidelines
Yeah,
there?
you can type, for example, is this patient following the guidelines for patients with diabetes recommendation? And I'm gonna explain to you why in the meantime. So basically, there are some guidelines, as you mentioned in the presentation, this one and before, that we need to follow. But the problem with these guidelines, sometimes it doesn't include older patients. So patients with dementia, for example, who are also with diabetes, with other comorbid conditions, you do not follow the strict guideline of controlling A1C between 7
Yeah.
and so. So there is liberation of that. So let's see here. Yeah, these are the
Here we go.
guidelines. Mhm.
So here we have the recommended glycemic target. So does AI, did ChatGPT do it correctly?
Yeah, so basically it will show you if you are following the guidelines and if you are not. So the last column here, under your cursor, you can see meeting the guidelines, two of them,
Okay.
and two of them
This
are not
one?
meeting that. And then here,
This one,
why
yeah.
is not, yeah, in the
Yeah.
green one, the green, that means you are following the guidelines. And the yellow, the X mark is not following the guidelines. So basically, in a younger patient, this will be useful. So you can show your patients that, hey, look at your blood sugars. We are not meeting the guidelines as far as this time and this medication and so on. And down, if you go down, it will show you what the issue, the major issues. If you go down number 3, what's the major issue here? It could be the blood sugars. Why are they high? Because of dehydration, infection, delirium, other something like that. So you think about that when you discuss with your patients. In this case, it's not of a big deal for me with my patients, older patients with blood sugar 300 maybe. I'll just continue adjust the medication, the insulin, and adjust the food items that they are eating, for example, consuming. So no big sugary items, something like that. This is guideline number 4, for example. So you want to follow the guideline as much as possible, but the caveat in older patients that you have to also look at the functional level of the patient, and you don't want to, it's say no harm. So first thing, you don't want to control it too tight that you end up with hypoglycemia in older patients. That's something like that. But this show you how you can, with minimal prompt, as Dr. Lojaine showed you, you can get some information, some recommendations, some guidelines, some analysis of your data, like in this case, blood sugars, and so on. Thank you so much. Any questions?
Dr. Nader, I do have a question actually.
Yes.
I was not sure on adding this, so I didn't know where like the guidelines exactly lie with HIPAA violations, and also I was going to write a prompt on how AI helps documentation in the US, but like I don't know how that lies because there has been some privacy concerns with ChatGPT. So is this legal in the US,
So
or how does it work?
basically, no, basically what there are some companies that are down now advocating or promoting their products. I think some of them are called scribe or scribe oriented kind of applications or products where you use the AI through them, and this will prevent HIPAA violation. So, for example, Doximity is a service or a company that help physicians. So they came up with a tool that can be used, and it's HIPAA compliant. Like you can dictate, and it will not save the data, but it will show you the same progress note like what you said or what you showed us now, and you can copy that note into the EMR, the actual EMR, so you don't violate the HIPAA, something like that. I think there is another one called Farida or Farid, also another AI transcribe or scribe tool, and I expect many more to come. In the big hospital, they use Epic, for example, an EMR, and within Epic, there is a dictation tool. So you dictate, and I think, if I'm not wrong, they incorporate the AI into that. So when you see the patient, it's going to be a common dialogue. Like, I'm going to ask the patient, do you have any pain? The patient says yes. I'm going to ask where. They said on my leg. Which leg? Left, right. So it's a conversation, but the AI will convert that into a SOAP note, like patient was seen, patient was complaining of right leg pain, and so on. So it's kind of a format that will help you get the note faster. Instead of you see the patient, you come back, you sit on the computer, you dictate, and then you review your note again and sign it, something like that. Thank you.
Oh, thank you so much. I do have another question. Last question, I promise.
Just go
So
ahead.
when it comes to like medical coding, are doctor responsible for this? Like I saw like International Classification of Disease, ICD-10. Is this a thing that I as an IMG, like I'm not really sure, like are we involved with that or is that another
So
thing?
during your training, that's a great question. So during your training, it's not required from you to understand. It's only for billing purposes and for, I think the idea is for EMR to talk to each other. So if you, in your hospital, you say in your note, this patient has hypertension, you type the word hypertension, the whole 10 letters or whatever. And then another patient or another doctor saw the same patient, but in another hospital. And instead of saying this patient came with hypertension, they put it as HTN. So the combination between them, we need to figure out HTN means hypertension. So they come up with the idea, the ICD-10. It has a version before that, ICD-9 and so on. And this will help identify specific conditions. And the more specific you are, the more you can use when we collect data. Let's say a patient who admitted to the hospital with diabetes, with foot wound and related to the diabetes, they have conditions resulted in amputation. So the amputation will be related to the ICD specific to which foot, and if there are toes, which type of toes, like left, right, and number 1, number 2 digits, and so on. For you at this level, you are not required to go that route. And when you are doing residency, you are not required to put the ICD-10. It will populate automatically in your chart. When you say hypertension, it will bring the ICD-10. For the hospital, though, or the training program, to get paid, they need to convert all this document or diagnosis into the ICD-10. So they send it to the billing department, and the insurance will pay them according to the ICD-10. So it's a back-end kind of like coding. You don't need to know coding. You don't know what's going on behind the codes, but you want just the front end. The same with notes of your training. We want you to know how to treat hypertension, how to treat congestive heart failure. You put that in your note and so on. The hospital, they have another team, or in this case, they can use AI to convert whatever diagnosis list into ICD-10, and then it will be used for billing purposes, if that makes sense. Or in the future for studies, like if I want to collect all patients with diabetes, I'm gonna just send to the IT, can you collect all the patients with this code, ICD code, and they will get me the report. Thank you.
Okay, thank you so much. That was very clear. Thank you, Dr. Nader.
Appreciate. Thank you. So for all these fellows attendees now, do you have any questions for Dr. Lojaine, or any questions for other presenters? Or if you have any updates, please let us know. Thank you.
Hello, Dr. Nader.
Hello, Dr. Ayah. Go ahead.
Yes, hi, good evening. I just want to thank you so much for this opportunity. Yes, and this great station so we can learn and develop. So I've been just attending like the last sessions here. It was very helpful and informative. And I just want to thank the presenters today. It was really like great presentation for each one of them. So just doctor, if I want to participate in the upcoming meetings, so where can I choose the topic I want to present, or how can I
Sure. First of all, welcome to the program, and I believe you are a new fellow to the program. And usually what we do, we group you as
Yes.
teams. So you will be in a team where the team will be assigned a date, and that day it will be whoever available in that team to present, and your team leader can arrange for that. In the meantime, anyone can present any topic wherever they are available. Let's say you are interested in next week topics. I'm going to share with you, for example, next week we're going to talk about the coming.
Yes.
Let's say you want to talk about cardiovascular disease number 2, which following topic number 1 today. So you will reach out to the pink leader team and say, hey, can I contribute or volunteer for topic number 1? And the team leader for that day, they will see who assigned for that, who will present that, and you can share with them. So the topic can be presented by 2 persons. Or if there is no one available to do that topic, you can go ahead and present that topic, if that makes sense.
Yes, and should I communicate using email?
So team leaders, if you look at the chat, there is a pink leader, so you can communicate with them. What are your questions? Sorry.
All right. Yes, that's great. Thank you so much.
You're welcome.
Dr. Nader,
Yes, go ahead, Dr. Malaz.
I would like to take a moment and thank you so much for this great opportunity. I truly look forward to our Saturday sessions. They have become an important part of my learning journey, and digital health is a field I'm genuinely passionate about. And presenting these topics every Saturday helps me understand the field more clearly, what is expected from me, and how I can continue to grow, and I feel that I'm learning and improving with every session. So again, literally, thank you so much for this great opportunity. And I would really value your advice, whether it's recommendations for AI-related training or certificate or guidance on new areas or projects using digital health. I'm very interested in working on projects related to digital health, and I would really appreciate your guidance. Thank you so much.
You're welcome, and thank you so much for your kind words. Yeah, everyone is encouraged to participate, and if you are interested in an area, you can also join a team where we work on certain areas. So currently, we are trying to submit some work related to AI, dementia, and so on, and diabetes also. So I'll put you on the list, and we'll see how we can work together. Thank you.
Okay. Thank you. Thank you. Thank you so much. I appreciate it.
You're welcome. All right. Any updates, any ideas, any comments before we adjourn? If not, I'd like to thank you so much, Dr. Rayan.
Thank you. Thank you so much, Dr. Yeah, thank you so
Okay,
much,
go ahead.
Dr. Nader. Yeah, thanks for the great presentation and for all the representer. I'm just asking you, Dr. Nader, if you can help us or hold the session regarding the soap. We applying this year, and we need to know how we handle that time if one of us, does not match in the main match, and he will find himself in the soap. If you can provide us with more information.
Sounds good. So I think during the the matching result will be
In March 20.
in March, yeah. So before March, maybe early weeks or end of February, we will put some sessions about the soap. And in the meantime, hopefully people will know something about it. And then we'll see how this is done, because it needs to be very aggressive and time
Yes.
short time notes.
Yes.
So we did that. If you go back to the meetings in let's say early March of last year, the year before, we did some sessions, so you can look at that. But we will try to do them this also March, and hopefully people will get updated and ready.
Yes, yes, and we hopefully all match this season.
Hopefully
but
we
we'll
get,
see.
we get
Yeah,
news.
yes, thank you
And there
so
are also
much.
other options nowadays. With in the past, some of the fellows from this program joined fellowships and then went back to residency and completed their residency. So there are other ways as well if you don't go through the matching.
Yeah.
Thank you.
Thank you so much. Thank you.
You're welcome. Once again, thank you so much, all of you. Thank you, Dr. Rayan. And if you want to add more comment, go ahead, Dr. Rayan.
Thank you so much, Dr. Nader. We finished. Thank you so much.
Thank you, and thank you to all presenters, and thank you to those who attended today's meeting, and it's also thank you to those who will come and watch the recording in the future. See you next week. If you have questions, please email me, text, or WhatsApp me. I'll help as much as I can, and we'll see you next week. Assalamu alaikum fi amantillah.
Wa alaikum assalam.
Alaikum assalam. Thank you.
وعليكم السلام ورحمة الله.
Salam. Thank you, Dr. Nader.